So if you completely stop feeding a patient, their gut doesn't just, like, take a break and rest.
Mm-hmm.
It actually physically begins to digest itself.
Yeah, it's brutal.
Right. The intestinal walls just crumble, the tight junctions between the cells completely fall apart, and then all those commensal bacteria that normally help us digest food, they just flood straight into the bloodstream.
Which is terrifying. We always kind of assume starvation is just this slow, quiet fading away.
Yeah.
But biochemically, I mean, it is an incredibly active, aggressive dismantling of the body's own internal architecture.
Exactly. And today, we are basically tearing down all those rigid textbook definitions of what the human body actually needs to survive. And, we are speaking directly to you right now.
The second-year medical student.
Yes, you. Sitting there, probably way too heavily caffeinated, just staring down the barrel of your board exams, getting ready to finally step onto the wards. And you are, no doubt, currently drowning in flashcards.
Oh, the flashcard fatigue is so real.
It's so real. You're just memorizing, like, what random vitamin deficiency caused, what weird disease name, just treating them like these isolated little trivia facts.
Right, and rote memorization might get you through a multiple-choice question on step 1,
Yep.
but I promise you it will completely fail you the exact moment a complex multi-system patient is actually sitting on the exam table right in front of you.
Yeah, 100%.
Because if you only memorize the symptom, you are always working backward. If we connect this to the bigger picture, malnutrition isn't just about starvation. It's really about the systemic, cascading consequences of cellular imbalances.
Okay, so let's unpack this.
Yeah.
Because food isn't just fuel, right? It's the literal signaling system for every single metabolic pathway we're about to explore today.
Exactly.
So for this deep dive, we are pulling from a really massive stack of sources, primarily centering on this exhaustive lecture framework. It's titled Nutrients and Diseases, 1092026.pdf, and it is just loaded with clinical diagrams, metabolic flowcharts, and medical nutrition therapy protocols.
It's a goldmine.
It really is.
Yeah.
So our mission today is to pull you out of that flashcard fatigue.
Yeah.
We are going to treat every disease, every syndrome, every deficiency as a biochemical mystery.
Yeah.
We're going to deeply understand the metabolic why and how that actually drives the clinical pathology.
Because the symptoms you see on the wards, right? The edema, the neuropathy, the altered mental status, they are just the logical, absolutely inevitable conclusions of a very specific biochemical pathway breaking down.
Yeah.
Once you understand the mechanism, the clinical presentation just makes intuitive sense. You don't even have to memorize it.
So true. So let's start right at the molecular foundation. We throw the word essential around constantly in medicine, I feel like. Essential amino acids, essential fatty acids.
Right.
But from a purely metabolic standpoint, the definition of that word is incredibly rigid.
Oh, it is entirely non-negotiable. I mean, an essential nutrient is a specific chemical compound required to sustain basic physiological functions that your human metabolic machinery simply lacks the enzymatic capability to synthesize.
You literally have to ingest it.
Right. If it is not in your diet, the pathway fails, the cells degrade, and pathology ensues. Full stop. This includes specific vitamins, minerals, a handful of amino acids, and, 2 specific fatty acids.
And then the flip side of that is the non-essential category. And I'll be honest, I have always kind of hated this term for clinical practice
Why is that?
because it implies the body just doesn't need them. But it actually means the exact opposite.
Yeah.
It means the body needs them so badly that it evolved the internal machinery to just manufacture them from scratch.
Oh, yeah, that's a great way to look at it. The endogenous factory is remarkably robust. Like, you take the non-essential amino acids, we can synthesize 11 of them entirely in-house.
Which is wild.
It is. The liver and peripheral tissues basically just pull carbon skeletons from the intermediates of glycolysis and the TCA cycle, the carboxylic acid cycle.
Right.
And they just slap an amino group on them.
Oh.
So as long as you have basic caloric intake and a nitrogen source, you don't actually need to eat them at all.
But, and this is where clinical medicine leaves the textbook and gets just incredibly complicated, we have the third category, the conditionally essential nutrients.
Ah, yes. This is the metabolic equivalent of surge pricing.
Surge pricing, I love that.
Under normal homeostasis, your internal factory handles the baseline demand perfectly. But biology is really dynamic. When a patient undergoes severe physiological stress, like massive trauma, overwhelming sepsis, third-degree burns.
Or even just the rapid growth phase of
That
pregnancy, right?
The demand for certain compounds just skyrockets way past the theoretical maximum output of your endogenous enzymes.
The supply line completely breaks down.
Yeah.
Let's actually ground this in a clinical scenario for you.
Yeah.
Say you are rotating through the burn unit. You have a patient with 40% total body surface area burns.
Very severe.
Extremely. They're in a massive hypermetabolic state, completely catabolic, literally trying to rebuild vast sheets of damaged tissue. In this scenario, we have to look really closely at an amino acid like arginine. Normally, arginine is just an intermediate in the urea cycle. We make it from citrulline. It's categorized as non-essential.
But under those burn conditions, the normal urea cycle synthesis of arginine is just a drop in the bucket compared to what the body is suddenly demanding.
Yeah.
Arginine is suddenly required in these massive quantities for cell division, for synthesizing collagen to actually close those burn wounds, and crucially, it is the direct biochemical precursor for nitric oxide.
And nitric oxide is fascinating here, right? Because in a severe trauma or a sepsis patient, the immune system desperately needs nitric oxide for vasodilation, for macrophage function, basically to fight off infection in those open wounds.
Exactly. And the demand for NO drains the entire arginine pool almost instantly.
Which means if you were the clinician calculating that patient's parenteral or enteral feeding formula.
Right, their tube feed.
Yeah. And you just treat arginine as non-essential and decide to leave it out. That patient's wound healing will completely stall, their immune response will falter, and their mortality risk climbs significantly. Arginine has become conditionally vitally essential.
Glutamine falls into this exact same trap, actually.
Oh yeah, glutamine is a huge one.
Because we synthesize it so easily from glutamic acid and free ammonia, we usually have more than enough lying around. You put a patient in the ICU with severe sepsis, and suddenly glutamine becomes the absolute hottest commodity in the entire body.
And the mechanism there is incredibly specific to the tissue type, isn't it?
It is. Glutamine is the preferred primary metabolic fuel for two very specific populations of cells. First, the enterocytes, which are the cells lining the gastrointestinal tract, and second, the rapidly dividing lymphocytes in your immune system.
Right.
So in a hypercatabolic septic state, your immune system is proliferating at maximum capacity trying to keep you alive, and your gut is under extreme ischemic stress. Those tissues essentially steal all available glutamine from your skeletal muscle reserves.
So if you don't proactively supplement it in their diet, the gut barrier literally begins to fail. Which takes us right back to that opening point we made about the gut dismantling itself.
It's just a complete cascading failure.
Now, trauma and burns are acquired conditions driving this surge demand. But the sources highlight a true clinical classic, one you are completely guaranteed to see on step 1 of your boards, where conditional essentiality is driven by a permanent genetic defect.
Phenylketonuria.
PKU. It's just a beautiful, if tragic, illustration of broken biochemistry. To understand PKU, we have to look at tyrosine.
Right, because tyrosine is normally non-essential.
No?
We have this dedicated enzyme, phenylalanine hydroxylase, or PAH, which basically just converts the essential amino acid phenylalanine directly into tyrosine.
It's just hydroxylates the aromatic ring. Super simple. But in PKU, the patient has this autosomal recessive mutation. So the PAH enzyme is either completely missing or just totally non-functional.
Or, occasionally, they are missing the crucial cofactor required for that enzyme to work, which is tetrahydrobiopterin, or BH4.
Right, the cofactor.
Either way, the enzymatic bridge is out.
The bridge is out.
Yeah.
So let's look at the downstream consequences of that. Because as a clinician, you aren't just treating a lab value. You're treating the metabolic fallout.
Yeah.
The immediate problem is the backup. Right? Phenylalanine cannot cross that bridge, so it just accumulates in the blood to highly toxic levels.
Yeah, it gets shunted into alternative pathways, creating phenylketones like phenylacetate and phenylactate.
And those are excreted in the urine, right? Which gives PKU patients that really classic musty body odor that the textbooks always mention.
Exactly. But the toxicity is severe, particularly to the developing central nervous system of a child. High levels of phenylalanine actively compete with other large neutral amino acids for transport right across the blood-brain barrier.
Oh, wow. So it just physically blocks them.
Yes. It essentially crowds out the competition, starving the brain of other necessary precursors, and that leads to severe intellectual disability, seizures, and microcephaly if it's not caught immediately at birth via newborn screening.
So that's the toxicity side of the disease. But the deficiency side is where this conditional essentiality kicks in. Because the bridge is out, Tyrosine is no longer being manufactured locally. So tyrosine is now 100% essential for this specific patient.
They absolutely must consume it in their diet.
And tyrosine isn't just structural. It is the starting material for some of the most critical molecules in human physiology.
Oh, absolutely. Tyrosine is the direct precursor for the entire catecholamine pathway.
Right.
It gets converted to L-BOPA, which becomes dopamine, which then becomes norepinephrine, which finally becomes epinephrine. So if you don't supplement tyrosine in a PKU patient, you are literally starving their sympathetic nervous system and their brain of basic neurotransmitters.
And it's also the precursor for melanin.
Yes. Which is exactly why untreated PKU patients classically present with very fair skin, blonde hair, and blue eyes, regardless of what their genetic background is.
Because the biochemical pathway to pigment is quite literally starved of its raw material.
Okay.
It's such a perfect example of why you don't just memorize PKU equals pale skin. You have to understand that PAH failure equals tyrosine deficiency, which equals melanin failure. The symptom just reveals the broken pathway.
You're just reading the biochemistry on the patient's skin.
Exactly. Now, to truly grasp how the body handles these amino acids, we have to talk about the waste management system, because protein metabolism is really messy.
Oh, it's incredibly messy.
Unlike carbohydrates or fats, which are pretty much just carbon, hydrogen, and oxygen that burn really cleanly into CO2 and water, amino acids contain nitrogen.
And free nitrogen, specifically in the form of ammonia, is wildly toxic to human biology. So the body employs this elaborate metabolic assembly line just to manage it. This is the process of transamination and deamination.
Right, so when a cell needs to use an amino acid for energy or maybe convert it into glucose, it first has to rip off that amino group. But it can't just throw it into the bloodstream, right?
No. It uses enzymes called aminotransferases, specifically ALT and AST.
Ah, which you'll measure on liver function tests constantly.
Right. And these enzymes require vitamin B6, pyridoxal phosphate, as a really crucial cofactor. So they take the amino group from the original amino acid and physically transfer it onto a receptor molecule, which is usually alpha-ketoglutarate.
And when alpha-ketoglutarate accepts that nitrogen, it transforms into glutamate.
Yes, glutamate acts as the universal funnel for the body. All across the body, in every single tissue, nitrogen is constantly being dumped onto alpha-ketoglutarate to form glutamate.
But glutamate can't just sit there in the peripheral tissue.
No, the nitrogen has to be physically transported to the liver because the liver is the only organ equipped with the full urea cycle necessary to package that nitrogen into a safe, water-soluble form, which is urea, for the kidneys to actually excrete.
Okay, so glutamate is the funnel, but it needs a shuttle to get to the liver. And here is where the elegance of muscle physiology comes in, specifically with the glucose-alanine cycle.
Oh, this cycle is brilliant.
It is. Let's say you are fasting and you decide to go for a long run. Your skeletal muscles are actively breaking down their own contractile proteins, specifically branched-chain amino acids, just to generate ATP. The nitrogen waste from that muscle breakdown gets funneled into glutamate.
And then the muscle takes that glutamate and transfers its nitrogen onto pyruvate, which is just the end product of glycolysis.
Right.
When pyruvate accepts that nitrogen, it becomes the amino acid alanine.
So alanine basically acts as this non-toxic, highly stable nitrogen submarine. It enters the bloodstream from the muscle, travels safely to the liver, and docks.
And in the liver, the whole process just runs in reverse. Alanine drops off its nitrogen to enter the urea cycle. Once alanine loses its nitrogen, it turns right back into pyruvate.
And the liver isn't going to waste that pyruvate.
Exactly. The liver then uses that pyruvate to run gluconeogenesis, creating fresh glucose, which it literally dumps right back into the blood for the muscle to use.
So the muscle sends waste, the liver safely disposes of the toxic nitrogen, and then sends back fresh fuel. It is this incredibly beautiful closed-loop system of energy supply and waste disposal.
It really is elegant.
But let's look at the pathology again. What happens when this system actually fails? What happens if you have a patient with advanced cirrhosis or massive hepatic necrosis, and the liver simply cannot run the urea cycle anymore?
Well, the whole shuttle system just backs up. The nitrogen cannot be converted into urea, so it begins to accumulate in the blood as free ammonia. And ammonia is a small, uncharged molecule at physiological pH, which means it freely, easily crosses the blood-brain barrier.
Oh, wow. And this is the exact mechanism of hepatic encephalopathy, isn't it?
Yes. You see a patient with severe liver disease presenting with confusion, severe lethargy, and asterixis, which is that classic flapping tremor of the hands you'll look for.
Biochemically, their brain is just drowning in ammonia.
Literally. And the brain tries to protect itself, right? Astrocytes in the brain attempt to mop up all that excess ammonia by basically forcing it onto glutamate to create glutamine.
Wait, but that creates two catastrophic problems.
Exactly. First, it completely depletes the brain's pool of glutamate, which, remember, is a major excitatory neurotransmitter.
Right. And second, glutamine is heavily osmotically active.
You nailed it. The massive accumulation of glutamine inside the astrocytes acts like a sponge. It pulls water from the blood directly into the brain cells. The astrocytes swell up, leading to severe cerebral edema, increased intracranial pressure, and eventually, if unmanaged, coma and death.
Wow.
The entire clinical presentation of hepatic failure isn't really just about the liver, it's about the downstream neurotoxicity of failed nitrogen disposal.
The interconnectedness is just staggering. All right, so we've watched the liver basically bend over backward to synthesize glucose from amino acids just to protect the brain, which raises a really massive question as we pivot to talk about the macronutrients, right? Carbohydrates, fats, and proteins. If the liver is that desperate to make its own sugar, pulling carbon skeletons from literally everywhere it can, why are we constantly told we must eat dietary carbohydrates to survive?
It's honestly one of the most pervasive myths in all of nutrition, and it frequently confuses the general public and even some clinicians.
Really?
Oh, yeah. The brain absolutely requires a constant supply of glucose, right? It consumes roughly 120 grams a day. If your glucose levels drop too low, you seize and you die.
Right. Hypoglycemia is an emergency.
Exactly. Therefore, the logical yet completely flawed leap is that you must consume carbohydrates to get that glucose. But biochemically, carbohydrates are entirely non-essential nutrients.
Because of gluconeogenesis, the liver is just the ultimate chemical refinery.
Through gluconeogenesis, the liver can synthesize every single molecule of glucose the body needs entirely from non-carbohydrate precursors. It utilizes the alanine we just discussed coming from muscle tissue. It uses lactate produced by red blood cells. It even uses the glycerol backbone from triglycerides when you break down your body fat.
I want to actually trace this out for the med student listening, because understanding the bottlenecks of gluconeogenesis is so critical for the boards.
Good idea.
So the liver takes pyruvate and uses an enzyme called pyruvate carboxylase. And that enzyme requires biotin as a cofactor of vitamin B7 to turn it into oxaloacetate.
Right.
Then an enzyme called PPCK converts it to phosphenol pyruvate, and it basically just runs glycolysis in reverse, all the way back up to glucose 6-phosphate.
And crucially here, the liver has the enzyme glucose 6-phosphatase, which basically chops off that final phosphate group, allowing the free glucose to exit the liver cell and enter the bloodstream to feed the brain.
Right, because muscle tissue completely lacks this enzyme, right?
Exactly, which is why muscle glycogen can only be used locally by that specific muscle. It cannot be shared with the rest of the body. Once glucose goes into a muscle, it doesn't come back out as glucose.
Okay, wait, let's play out a clinical scenario here. A patient decides to go on a strict, zero-carbohydrate ketogenic diet. They are eating only protein and fat. If the brain needs glucose and we completely stop eating carbs, how long does the liver's stored glycogen actually last?
Honestly, liver glycogen is a very limited reservoir. In a completely fasted state or a strict zero-carb environment, liver glycogen is largely depleted within about 18 to 24 hours.
Wow, so after a single day, gluconeogenesis isn't just like a helpful backup system. It is the sole mechanism keeping the lights on in the central nervous system.
Precisely.
But the liver can't just do this indefinitely without help, right? I mean, if it just kept converting muscle protein into glucose, we'd waste away in a matter of weeks.
Which is exactly where ketogenesis steps in to save our muscle mass.
Okay, how does that work?
Well, as gluconeogenesis really ramps up, it massively depletes the liver's oxaloacetate. And without oxaloacetate, the TCA cycle in the liver starts to slow down. Meanwhile, the body is breaking down massive amounts of stored body fat, which floods the liver with acetyl-CoA.
So acetyl-CoA is just piling up, but it can't enter the TCA cycle because all the oxaloacetate is being stolen for gluconeogenesis.
Exactly. So the liver's like, what do I do with all this acetyl-CoA? It shunts it all into a completely different pathway. The synthesis of ketone bodies, specifically acetoacetate and beta-hydroxybutyrate.
Right.
The liver pumps these ketones straight into the blood. And the brain, which usually only uses glucose, is remarkably adaptable. Within just a few days of zero carbohydrates, the brain alters its enzyme expression and actually begins using ketone bodies for up to 70% of its total energy needs.
Which is incredible. That drastically reduces the brain's demand for glucose, which then drastically reduces the need for gluconeogenesis, which ultimately spares our muscle tissue from being broken down for its amino acids.
It is a brilliant evolutionary survival mechanism for times of famine, and it proves definitively that dietary carbohydrates are, in fact, non-essential.
Wow. And we see a really similar physiological misunderstanding with dietary cholesterol, don't we? Like, patients in the clinic will be absolutely terrified of eating an egg because of the cholesterol content.
Oh, all the time, but the actual dietary requirement for cholesterol is exactly zero.
Zero.
Zero. Every single cell in the human body can synthesize its own cholesterol, though the liver obviously handles the vast majority of it. It synthesizes it de novo entirely from acetyl-CoA. The rate-limiting step there is the enzyme HMG-CoA reductase.
Which is the exact target of statin drugs.
Exactly. We pharmacologically inhibit that specific enzyme to lower internal production.
And the regulatory feedback loop here is just fascinating to me.
It is. When you consume dietary cholesterol, the liver senses it via these sterile regulatory element binding proteins, or SRABPs, and the liver simply downregulates its own endogenous production to balance it out.
So it just makes less if you eat more.
Right. This is why, for the vast majority of the population, dietary cholesterol has a clinically insignificant impact on their serum LDL levels.
It's the saturated and industrial trans fats that actually disrupt the LDL receptor recycling, leading to high serum cholesterol, not the literal cholesterol molecule in the food itself.
Correct.
Speaking of things we make ourselves, let's look at the vitamins we assume are essential, but actually exist in this weird gray area, vitamin D and vitamin K.
Right. Vitamin D, cholecalciferol, is barely even a vitamin. It operates much more like a steroid hormone. We synthesize it right in the skin from a cholesterol precursor called 7-dehydrocholesterol. But this endogenous synthesis requires a highly specific environmental catalyst.
Ultraviolet B radiation from sunlight.
Yes. The UV light physically breaks a carbon ring in the molecule, creating pre-vitamin D3, which then undergoes thermal isomerization into D3.
But that's just the precursor, right? It has no biological activity yet.
All right, it's inactive. It has to travel to the liver, where the enzyme 25-hydroxylase adds a hydroxyl group. Then it travels to the kidneys, where the enzyme 1-alpha-hydroxylase, which, by the way, is heavily regulated by parathyroid hormone, or PTH, adds a final hydroxyl group to create 1025-dihydroxycholocalciferol.
And that is the active, potent hormone that travels to the gut to ramp up calcium-binding proteins, basically allowing you to absorb calcium from your diet.
Exactly.
So vitamin D becomes conditionally essential based on geography and lifestyle. Like if you have a patient in Seattle working night shifts, or an elderly patient in a nursing home who literally never sees the sun, that UV catalyst is just missing.
The endogenous factory shuts down completely.
And they absolutely require dietary vitamin D to prevent hypocalcemia, secondary hyperparathyroidism, and eventually osteomalacia or rickets.
And then vitamin K2, anakinone, represents a completely different kind of endogenous synthesis, because we actually don't make it.
Where we don't.
Nope. The trillions of commensal bacteria living in our large intestine, specifically strains of bacteroids and E. coli, they synthesize it for us as a byproduct of their own metabolism.
Oh, wow. And we just absorb it directly across the colonic mucosa.
Yep. It's this incredible symbiotic relationship. But again, clinical context matters so much here. If you prescribe a patient 3 weeks of broad-spectrum oral antibiotics for an infection, you aren't just killing the pathogen.
You're basically napalming the gut microbiome.
Exactly. You wipe out the internal K2 factory. Now, while we still absorb K1 from leafy greens, the disruption of the microbiome can lead to a subclinical vitamin K deficiency, and that impairs the gamma carboxylation of clotting factors 2, 7i, and X in the liver, which subtly but dangerously increases their bleeding risk.
Wow, the body is just entirely interconnected. Let's actually move from these micromechanisms back up to the bulk of our diet, the macronutrients. We know carbs and proteins yield roughly 4 kilos per gram, and fats yield 9. But as a clinician, counting calories is way less important than understanding how these fuels are actually metabolized. Specifically, looking at the respiratory quotient, or RQ.
Ah, the respiratory quotient. This is a very high-yield physiological concept for students. It is simply the ratio of carbon dioxide produced by the body to the oxygen consumed during metabolism.
Let's ground this for everyone. You are an ICU resident. You have a patient with severe chronic obstructive pulmonary disease, COPD, who has been intubated on a ventilator for a week. You're trying to wean them off the vent so they can breathe on their own, but every single time you try, they fail. Their CO2 levels spike, they become acidotic, and they fatigue immediately. Why?
You have to look at their feeding tube formula. The metabolism of carbohydrates has an RQ of 1.0. This means for every single molecule of oxygen consumed to burn a carbohydrate, 1 molecule of CO2 is
It
produced.
is a very gassy fuel, essentially.
Exactly. Conversely, the metabolism of lipids, fats, has an RQ of about 0.7, so burning fat consumes more oxygen relative to the amount of CO2 it actually produces.
So if you were feeding that COPD patient a high carbohydrate formula, their metabolism is generating massive amounts of CO2 just from digesting it.
Right, and a healthy person just breathes a little faster to blow it off. But a COPD patient has severely compromised lungs. They physically cannot exhale that excess CO2.
Right.
It builds up, causing respiratory acidosis, and they fail the ventilator weaning trial.
And the fix is entirely nutritional. You just switch their enteral feed to a high-fat, low-carbohydrate formula. The RQ drops, their total CO2 production drops, the burden on their lungs decreases, and suddenly they can finally breathe on their own.
That is the power of understanding metabolic pathways over just blindly counting calories.
Absolutely. Now, when we do talk about carbohydrates in a general outpatient setting, the critical concept from the sources is the glycemic index. And I want to stress, this isn't just some diet fad. It is a profound measurement of physiological stress.
It really is. The glycemic index measures the speed and intensity at which a specific carbohydrate breaks down into glucose and enters the bloodstream. Highly processed, refined carbohydrates, think white bread, sugary sodas, instant rice, they have a very high GI.
Because the digestive enzymes just cleave those simple bonds almost instantly in the small intestine.
Right, and the glucose just floods through the GLUT2 transporters in the enterocytes directly into the portal vein. The liver gets hit with an absolute tsunami of sugar.
And the body perceives this massive spike in blood glucose as a severe homeostatic threat, doesn't it?
Oh, absolutely. Hyperglycemia is toxic. It causes osmotic damage and non-enzymatic glycation of proteins all over the body. So the beta cells in the pancreas respond to this emergency by dumping an enormous bolus of insulin straight into the blood.
So insulin travels to the skeletal muscles and adipose tissue, binds to the insulin receptors, and triggers an intracellular signaling cascade that essentially forces GLUT4 transporters to the cell surface to vacuum the glucose out of the blood.
But because the initial spike was so aggressive, the insulin response almost always overshoots. The glucose is cleared way too rapidly, leading to reactive hypoglycemia.
Her blood sugar just crashes.
Exactly. And when blood sugar crashes, the brain panics. It triggers intense counter-regulatory hormones like glucagon, cortisol, epinephrine, and it signals extreme hunger.
So the patient feels starved and fatigued despite having just eaten a massive caloric load like an hour ago.
Yes. This drives a vicious cycle of overeating. But the long-term pathology is even more insidious. If a patient chronically consumes high GI foods, the cells are constantly bombarded by massive surges of insulin.
And over time, to protect themselves from pulling in too much glucose and literally exploding osmotically, the peripheral cells begin to downregulate their insulin receptors, right?
Right. They become insulin resistant.
So the pancreas has to pump out even more insulin just to force the glucose in.
And this hyperinsulinemia drives relentless weight gain because insulin is the ultimate anabolic fat-storing hormone. Eventually, the overworked beta cells in the pancreas undergo apoptosis. They literally burn out and die, leading to full-blown type 2 diabetes.
It's a tragic cascade. But conversely, complex carbohydrates, legumes, whole grains, raw vegetables, they are rich in dietary fiber.
And the fiber acts as a physical barrier in the gut, slowing down that enzymatic cleavage. So the glucose is released slowly and steadily, the insulin response is gentle, the cells remain sensitive to it, and satiety is maintained for hours.
Which leads perfectly into how the body handles excess. Let's say you eat a massive meal of high GI carbs, far more than your glycogen stores can actually hold. The body doesn't waste energy. It initiates de novo lipogenesis. It basically turns that sugar into fat.
Yes. The liver takes the excess acetyl-CoA that isn't being run through the TCA cycle and uses the enzyme acetyl-CoA carboxylase, which again requires biotin to turn it into malonyl-CoA.
Right.
Then, fatty acid synthase builds a long hydrocarbon chain, specifically creating palmitic acid.
Palmitic acid 16.0, a 16-carbon fully saturated fat.
Yes. Palmitic acid is the primary end product of endogenous fat synthesis, and clinically it is highly problematic. Elevated levels of endogenous palmitic acid are strongly correlated with cellular lipotoxicity, systemic inflammation, and worsening insulin resistance. It actively damages your metabolic machinery.
But I love the nuance in the sources here, because it highlights that not all saturated fats behave the exact same way. The liver can actually take that palmitic acid and use an elongase enzyme to add 2 more carbons, creating stearic acid 18.00.
Right. And even though stearic acid is also a saturated fat, Structurally, its 18-carbon chain interacts totally differently with cellular receptors. Unlike palmitic acid, stearic acid has a relatively neutral effect on serum LDL cholesterol levels. It doesn't seem to drive the same inflammatory atherogenic pathways.
And we can take it a step further. The liver can also use a desaturase enzyme to insert a double bond into palmitic acid, creating palmitoleic acid, 16.1, and omega-7 monounsaturated fat. And the sources actually refer to this as a lipokine.
I love that term. A lipokine functions exactly like an endocrine hormone, but it's a lipid. When the liver is overwhelmed by excess carbohydrates and is churning out massive amounts of fat, it releases this palmitoleic acid into the bloodstream.
Where does it go?
This fat molecule travels to skeletal muscle and adipose tissue, actively signaling the body's metabolic status. It basically acts as an early warning biomarker that the liver is undergoing severe stress and excessive lipogenesis.
It's basically the liver pulling the fire alarm for metabolic syndrome and non-alcoholic fatty liver disease. All right, we are moving from the macro down to the micronutrient minefield. We've discussed what happens when fuel is unbalanced. Now we need to explore what happens when the cellular spark plugs the vitamins and minerals are just completely missing.
Okay.
And listener, before we dive into the specific pathologies, the sources provide a very direct, honestly uncomfortable reality check specifically for you.
Yes, they do. The document cites a 2025 study by Aga et al., specifically analyzing the nutritional status of medical students.
Oh boy.
And it found that despite having advanced knowledge of physiology and biochemistry, medical students are a profoundly high-risk population for subclinical vitamin deficiencies.
Because, I mean, you know the Krebs cycle backward and forward, but at 3 a.m., when you've been studying for 14 hours, you aren't eating a balanced meal. You are surviving on, like, vending machine pretzels and energy drinks.
And the data explicitly links this specific lifestyle, chronic academic stress, severe sleep deprivation, and ultra-processed convenience diets to actual physiological consequences. The deficient medical students exhibited statistically significant increases in chronic fatigue, higher rates of upper respiratory infections due to impaired immunity, and measurable deficits in cognitive concentration and memory retention.
So you are actively handicapping the exact organ you need most right now. So please, listen to this next section not just as a clinician, but as a patient. Let's divide vitamins into water-soluble and fat-soluble.
Sounds good.
Let's start with the water-soluble B complex and vitamin C. These are not stored in bulk, meaning a constant dietary supply is absolutely mandatory. Let's look at vitamin B1, thiamine.
Thiamine is huge. It's converted into its active form, thiamine pyrophosphate, or TPP. And TPP is an absolutely mandatory cofactor for 4 major enzymes in human metabolism. If you want to really understand the pathology of B1 deficiency, you just look at what fails when these enzymes stop working.
Oh, let's actually list them out. Pyruvate dehydrogenase, or PDH, which links glycolysis to the TCA cycle.
Right, and alpha-ketoglutarate dehydrogenase, which is a critical step inside the TCA cycle itself.
Then there's transketolase, which runs the pentose phosphate pathway.
And finally, branched-chain ketoacid dehydrogenase, which breaks down amino acids in the muscle.
Notice the pattern there. 3 of those 4 enzymes are fundamental bottlenecks for generating ATP from glucose. Therefore, a thiamine deficiency is essentially a massive energy crisis at the cellular level.
Exactly. The tissues that suffer first, and frankly most severely, are the ones with the highest baseline demand for ATP. The heart and the brain.
Clinically, you will almost exclusively see severe thiamine deficiency in chronic alcoholics, because alcohol both severely impairs the intestinal absorption of thiamine and it depletes the liver's storage capacity.
Right. So when the heart feels from this ATP crisis, we call it wet Marbury. The myocardial cells literally lack energy, the heart dilates, cardiac output drops, and fluid backs up into the lungs and peripheral tissues, causing severe edema.
And when the peripheral nervous system fails, it's dry beriberi, symmetrical peripheral neuropathy, severe muscle wasting, absent reflexes. But the most catastrophic presentation is in the central nervous system, right? Wernicke-Korsakoff syndrome?
Yes. Wernicke's encephalopathy is the acute phase. The brain regions highly dependent on glucose metabolism, specifically the mammillary bodies and the medial dorsal nucleus of the thalamus, undergo microhemorrhages and necrosis.
Wow. And the patient presents with that classic triad: confusion, ophthalmoplegia, which is paralysis of the eye muscles causing this abnormal gaze and profound ataxia, or loss of physical coordination.
And if you miss this, or tragically, if you give a hypoglycemic alcoholic a glucose IV without giving them thiamine first.
Oh, that is a fatal clinical error.
It is, because giving glucose forces the body to rapidly ramp up glycolysis, which suddenly demands massive amounts of TPP for the pyruvate dehydrogenase enzyme. You instantly burn through whatever microscopic reserves of thiamine the patient has left, precipitating immediate, irreversible brain damage.
And then it progresses to Korsakoff syndrome, right? The necrosis just becomes permanent. The patient develops profound anterograde and retrograde amnesia. They lose the ability to form new memories, and they exhibit confabulation.
Right, their brain invents elaborate false stories to fill the gaps in their memory, and they genuinely believe them. It is devastating to witness.
Okay, let's move to vitamin B3, niacin.
Niacin is the precursor for NAD and NADP, the primary electron carriers in the cell. Every redox reaction, every step of ATP generation requires NAD to carry hydrogen electrons to the electron transport chain.
Now, we mentioned earlier that we can actually synthesize niacin from the essential amino acid tryptophan, but it's brutally inefficient, right? Like 60 milligrams of tryptophan just to make 1 milligram of niacin.
Which perfectly explains the historical and clinical presentation of pellagra, the niacin deficiency disease. Historically, it ravaged populations that relied on untreated maize or corn as their primary caloric source.
Because corn is severely deficient in tryptophan.
Exactly. And the niacin it does contain is tightly bound and biologically unavailable unless the corn is treated with an alkali solution like lime water.
So these populations were missing the vitamin and the precursor. And the clinical presentation is the brutal 4Ds.
Dermatitis, specifically in sun-exposed areas, presenting as a severe, blistering, symmetrical rash known as Casal's necklace around the neck.
Diarrhea, because the rapidly dividing epithelial cells of the gut lack the NAD to generate energy, so the gut lining literally just slows off.
Dementia, as the neurons fail, and ultimately, death.
And as a med student, you need to connect pellagra to 2 other pathologies that steal tryptophan. First, carcinoid syndrome, where a neuroendocrine tumor steals all the body's tryptophan to overproduce serotonin.
Right.
And Hartnett disease, a genetic defect where the kidneys and gut cannot absorb neutral amino acids like tryptophan. Both conditions can present with pellagra-like symptoms because the raw material for niacin synthesis is just gone.
That's a great clinical connection.
Let's finish up the water-soluble vitamins with the structural masterclass. Vitamin C and scurvy.
Scurvy is characterized by bleeding gums, corkscrew hairs, petechiae, which are pinpoint hemorrhages under the skin, and crazily old scars suddenly bursting open.
And the biochemical explanation for every single one of those symptoms lies in the rough endoplasmic reticulum of fibroblasts. We discussed the amino acid proline earlier, right? Collagen, the most abundant structural protein in the human body, is essentially a triple helix made heavily of glycine, proline, and lysine.
But for that triple helix to twist tightly and bond together into a really strong structural cable, the proline and lysine residues must be hydroxylated. They need an OH group added to them.
Okay.
The enzymes that do this, prolyl hydroxylase and lysyl hydroxylase, strictly require vitamin C as an electron donor to maintain their iron cofactor in the correct reduced state.
So without vitamin C, the enzymes stall. You cannot hydroxylate the proline.
Exactly. The collagen triple helix is synthesized, but it cannot cross-link. It is structurally weak, like building a skyscraper with rubber rebar instead of steel.
Which is why the symptoms manifest where structural integrity is most critical. Blood vessel walls rely on collagen. Without it, the capillaries simply rupture under normal blood pressure, causing the petechiae and bleeding gums.
And scar tissue is literally just a matrix of collagen. So without vitamin C, the collagen degrades, and years-old healed wounds can literally unravel and open up.
It's not a mystery disease at all. It's just a complete failure of structural biochemistry.
Exactly.
Now, let's look at the fat-soluble vitamins, A, D, E, and K. Because they dissolve in lipids, they are actually stored in the liver and adipose tissue.
Which introduces a completely different clinical risk profile. Toxicity. You don't just pee out the excess like you do with B vitamins.
Right.
Hypervitaminosis A, for instance, from massive supplement intake, leads to severe hepatotoxicity, increased intracranial pressure mimicking a brain tumor, and it is highly teratogenic, disrupting normal gene expression in a developing fetus.
But the more common clinical scenario you will actually face is deficiency. And here is the pearl. If a patient is deficient in A, D, E, and K simultaneously, you don't send them to a nutritionist. You send them to gastroenterology.
Because it is rarely a dietary intake problem in the developed world, it is almost always a malabsorption problem. If the gut cannot absorb fat, it cannot absorb the vitamins dissolved within that fat.
So you look for celiac disease, where an autoimmune reaction to gluten has physically destroyed the absorptive villi of the small intestine, or cystic fibrosis, right?
Oh, absolutely. In CF, thick mucus blocks the pancreatic duct, preventing lipase enzymes from reaching the gut. That means fats are never broken down and are just excreted in the stool, a condition called steatorrhea.
And the vitamins are just trapped in the unabsorbed fat and flushed away. Let's do a deep dive on one specific differential diagnosis that bridges vitamins and hematology. A patient presents with profound fatigue. You run a complete blood count, a CBC. You see macrocytic megaloblastic anemia. The red blood cells are enormous and immature. You narrow it down to two suspects, vitamin B12, cobalamin deficiency, or vitamin B9, folate deficiency. How do you differentiate them biochemically and clinically?
This is a classic board question. Both B12 and folate are absolutely critical for the synthesis of purines and pyrimidines, the building blocks of DNA.
Right.
When you are deficient in either, rapidly dividing cells like red blood cell precursors in the bone marrow can synthesize RNA and proteins to grow large, but they cannot replicate their DNA to actually divide, so they get stuck as massive, immature megaloblasts.
But B12 has a second, completely unique job that folate doesn't share, doesn't it?
Correct. B12 is the necessary cofactor for the enzyme methylmalonyl-CoA mutase, which is required to metabolize odd-chain fatty acids and branched-chain amino acids. If you lack B12, this pathway halts, and methylmalonic acid, or MMA, builds up to toxic levels.
And this buildup is devastating to the nervous system.
Very much so. The abnormal fatty acids get incorporated into the myelin sheath that insulates neurons, causing it to degrade. This leads to subacute combined degeneration of the spinal cord.
Wow. And clinically, the patient presents with loss of vibration and position sense, spastic weakness, and severe peripheral neuropathy.
Right. But folate deficiency does not cause this specific pathway to back up. So folate deficiency gives you the anemia but no neurological symptoms. B12 deficiency gives you the anemia plus the neuropathy.
And you can confirm it in the lab by checking serum methylmalonic acid, MMA, levels. In folate deficiency, MN is normal. In B12 deficiency, MMA is highly elevated because the mutase enzyme is stalled.
That is the exact kind of deductive reasoning you need for the wards.
All right, we have mastered the micro and the macro. It is time to enter section 4, the bigger picture. We are zooming out to the epidemiological level to understand how these cellular derangements drive a global burden of non-communicable diseases, or NCDs.
Historically, the global health focus was singular, undernutrition. We looked at severe acute malnutrition syndromes like marasmus and kwashiorkor, which predominantly impact children in developing nations.
Let's clarify the pathophysiology between those two because they look very different on presentation. Marasmus is a total deficiency of both calories and protein.
It is severe, prolonged starvation. The body mounts an intense catabolic response, breaking down all subcutaneous fat and skeletal muscle to provide amino acids for gluconeogenesis. The child looks incredibly emaciated, basically skin and bones, with the classic old man face due to the loss of buccal fat pads.
But crucially, serum protein levels, like albumin, often remain surprisingly normal for a long time in marasmus, right? Because the liver is aggressively synthesizing them from the scavenged muscle tissue.
Exactly. Kwashiorkor, however, is a protein-specific deficiency in the presence of adequate or even excess caloric intake, usually from a diet relying solely on starchy, low-protein carbohydrates like cassava or yam.
And the pathophysiology here is driven by the liver's failure to synthesize two key proteins. First, the liver lacks the amino acids to make albumin.
And albumin is the primary protein responsible for maintaining intravascular oncotic pressure, the osmotic force that actually holds water inside the blood vessels.
So without albumin, the oncotic pressure plummets, and fluid leaks out of the capillaries and pools in the interstitial spaces.
This causes the massive hallmark edema, particularly the swollen, distended abdomen.
And the second failure is the inability to synthesize apolipoproteins. The liver is still taking in dietary carbohydrates and converting them into fat via de novo lipogenesis, but without apolipoproteins, it cannot package those fats into VLDL particles to ship them out to the rest of the body.
The fat literally just gets trapped. The liver cells become engorged with triglycerides, leading to severe hepatomegaly, a massively enlarged fatty liver, edema, and a fatty liver. That is the biochemical signature of kwashiorkor.
But the global paradigm has shifted recently. The sources emphasize the double burden of malnutrition. We now have populations where undernutrition coexists alongside an explosion of overnutrition, specifically obesity and diet-related non-communicable diseases.
The numbers are frankly staggering. 2.5 billion adults globally are overweight. 890 million are living with obesity. And it's driven by a fundamental shift in the global food supply toward ultra-processed, energy-dense, nutrient-poor foods.
Let's trace how this diet directly builds the pathology of cardiovascular disease, CVD. We mentioned earlier how saturated fats and trans fats elevate LDL cholesterol, but how does that actually cause a heart attack?
Well, it's an inflammatory process. When
Fair.
LDL particles circulate in the blood for too long, they penetrate the endothelial lining of the arteries.
Okay.
In the subendothelial space, the lack of dietary antioxidants, because the patient isn't eating fruits or vegetables, allows those LDL particles to become oxidized by free radicals.
And the immune system sees this oxidized LDL as a foreign pathogen. Macrophages rush in and begin engulfing the oxidized fat.
But they can't break it down. The macrophages literally eat themselves to death, becoming bloated, lipid-filled foam cells.
Oh.
These foam cells accumulate, die, and form a necrotic, lipid-rich core in the artery wall.
And then smooth muscle cells migrate over it to form a fibrous cap, creating an atherosclerotic plaque.
Yes. If that fibrous cap ruptures, it triggers the clotting cascade. A thrombus forms instantly, occluding the coronary artery, cutting off oxygen to the myocardium. That is a myocardial infarction.
Which is exactly why the Mediterranean and DH diets are so highly recommended. It isn't just about reducing saturated fat. These diets provide massive amounts of phytochemicals, polyphenols, and antioxidant vitamins that actively neutralize those free radicals in the blood.
Right, preventing the oxidation of LDL in the first place, stopping the inflammatory cascade before it even starts.
And the same processed, high GI diets drive type 2 diabetes.
So,
We traced the insulin resistance earlier, the downregulation of GLUT4 receptors, but eventually the hyperglycemia itself becomes toxic to the pancreas.
Glucotoxicity. The chronic high blood sugar causes severe oxidative stress inside the pancreatic beta cells, leading to the misfolding of proteins and the deposition of amyloid fibrils inside the islets of Langerhans.
Wow.
The beta cells physically destroy themselves, shifting the patient from insulin resistance to absolute insulin deficiency.
The sources also explicitly link these dietary patterns to certain cancers, particularly colorectal cancer.
And the mechanism there is heavily influenced by the gut microbiome. A diet low in dietary fiber deprives the commensal bacteria of their primary fuel source. Normally, bacteria ferment fiber into short-chain fatty acids, specifically butyrate.
And butyrate is fascinating. It's the primary energy source for colonocytes, the cells lining the colon.
It also acts as a potent anti-inflammatory and anti-tumor agent, actively promoting apoptosis in cells with DNA damage.
So without fiber, butyrate production plummets. The colonocytes are starved, inflammation rises, and the intestinal epithelium is far more susceptible to the carcinogenic nitrosamines found in highly processed meats. The lack of fiber physically alters the tissue environment to favor malignant transformation.
It's all connected.
Speaking of tissue environments, the sources detail a critical bidirectional relationship between nutrition and immunity. We intuitively know that malnutrition weakens the immune system. Without protein to build immunoglobulins or zinc to act as a cofactor for immune cell proliferation, you are highly susceptible to infection.
But the vicious cycle is that infection actively drives malnutrition. When a patient contracts an infectious disease, say severe gastroenteritis or pneumonia, their basal metabolic rate spikes, often by 10% for every degree Celsius of fever.
The body is burning immense energy just to run the immune response.
Simultaneously, the immune system releases cytokines like tumor necrosis factor alpha and interleukin-1. These inflammatory markers act directly on the hypothalamus to profoundly suppress appetite.
So the metabolic demand is at its absolute highest, and the caloric intake drops to zero.
And if it is an enteric infection, the pathogen often damages the intestinal villi, causing severe malabsorption. Whatever food is consumed just passes through unabsorbed, often pulling water with it, worsening dehydration and nutrient loss.
So the malnutrition makes the infection more severe, and the infection deepens the malnutrition. Breaking this cycle is arguably the most important intervention in pediatric global health. Which brings us perfectly to our final arena, Section 5, clinical application. We know the biochemistry, we know the pathology, we know the epidemiology. Now, you are on the wards. You have a critically ill patient who cannot physically eat. How do you intervene?
You apply medical nutrition therapy, MNT, guided by the Nutrition Care Process or NCP framework. You don't just guess what the patient needs, you execute a systematic evaluation. assessment, diagnosis, intervention, and monitoring.
Let's focus on assessment. You can't just look at a patient and know their nutritional status. You have to look at the labs, and you have to understand the half-lives of the proteins you are actually measuring.
Oh, this is a classic clinical trap. Many clinicians look at serum albumin to gauge a patient's current nutritional status, but albumin has a half-life of about 20 days.
So it tells you what their nutritional status was 3 weeks ago.
Exactly. If a patient was in a massive car crash 2 days ago, their albumin might still be perfectly normal, even if they're in a massive hypercatabolic state right now. Instead, you measure prealbumin, which has a half-life of only about 2 days. It gives you a much more acute, real-time picture of their visceral protein synthesis.
Okay, so once you assess and diagnose the deficit, you move to intervention. The two massive pillars of clinical nutrition support are enteral feeding and parenteral feeding.
And the decision between these two dictates the patient's entire clinical trajectory.
Here's the framework I use to visualize it. Think of the gastrointestinal tract as a highway system. Enteral feeding is putting cargo trucks on the highway that is already built. It uses the normal infrastructure.
I like that.
Parenteral feeding, on the other hand, is airdropping supplies from a helicopter directly into the bloodstream, because the highway is either completely destroyed or physically blocked.
That is precisely it. Enteral means it enters the GI tract at some point. If it's short-term, say a patient have acute dysphagia after a stroke, you use a nasogastric or NG tube running from the nose down into the stomach.
But if they have severe gastric reflux or gastroparesis where the stomach doesn't empty, you push the tube further down past the pyloric sphincter, nasoduodenal or nasojejunal tubes.
And for long-term enteral needs, perhaps a patient with head and neck cancer who physically cannot swallow but whose GI tract works perfectly fine, you bypass the face and esophagus entirely. You surgically place a PEG tube percutaneous endoscopic gastrostomy directly through the abdominal wall into the stomach, or a jejunostomy directly into the small intestine.
Now, what about the airdrop? Parenteral nutrition.
Parenteral is intravenous. It bypasses the digestive system entirely. Peripheral parenteral nutrition, PPN, is given via a standard high-V in a peripheral vein in the arm. The limitation here is osmolarity. You cannot infuse highly concentrated solutions of glucose and amino acids into a small peripheral vein. The osmotic pressure will physically destroy the vein lining, causing severe phlebitis.
So PPN is only for short-term partial support. If a patient needs 100% of their calories intravenously, you have to use total parenteral nutrition, TPN.
TPN requires a central venous catheter, a line threaded directly into the superior vena cava right above the heart. The blood volume and flow rate there are so massive that it instantly dilutes the highly hypertonic, concentrated nutritional formula, preventing vascular damage. TPN is a literal lifesaver.
But it comes with massive risks, specifically refeeding syndrome. I want to emphasize this because it straight up kills patients.
It does.
Let's say you have a patient with severe anorexia nervosa or someone who's been lost in the wilderness and starved for weeks. They arrive at the hospital and you hook them up to TPN, pumping massive amounts of glucose directly into their blood.
What happens? Well, the pancreas, which has been basically dormant, suddenly senses this massive influx of glucose and dumps a huge surge of insulin. And insulin doesn't just push glucose into cells, it vigorously drives electrolytes, specifically phosphate, potassium, and magnesium from the blood into the intracellular space to help process that glucose.
But the starved patient already has critically low total body stores of these electrolytes.
Right, so when insulin forces the little remaining phosphate out of the blood and into the cells, the serum phosphate levels plummet to near zero. Profound hypophosphatemia.
And without phosphate, the cells cannot synthesize ATP. The cardiac muscle runs out of energy, leading to fatal arrhythmias, respiratory failure, and sudden cardiac death. That is refeeding syndrome.
You must reintroduce calories agonizingly slowly while aggressively supplementing and monitoring intracellular electrolytes.
TPN is dangerous. Central line infections, liver dysfunction, refeeding syndrome, which leads us to the ultimate clinical mantra regarding nutrition support. If the gut works, use it.
It is the golden rule of critical care. If you rely entirely on TPN and leave the GI tract empty, the gut architecture collapses.
Let's look at the mechanism. Enteral feeding isn't just about delivering calories to the blood. The physical presence of food in the lumen acts like physical therapy for the intestinal tissue. It's the dumbbell that keeps the gut strong.
The enterocytes of the small intestine derive a significant portion of their energy directly from the glutamine in the luminal food passing over them, not just from the blood supply. And the cholelindrocytes rely on the short-chain fatty acids produced by bacteria fermenting the dietary fiber.
So if you stop enteral feeding, you are literally starving the intestinal lining itself, even if you're pumping TPN into the vein.
The villi blunt and atrophy. The tight junctions between the cells degrade.
And the mucosal immune system, the diastole, weakens. When that barrier breaks down, the trillions of bacteria in the gut simply translocate. They cross the compromised wall directly into the bloodstream, triggering massive systemic inflammatory response syndrome and septic shock.
So even if a patient is receiving 90% of their calories via TPN because of a partial bowel issue, you still trickle a tiny amount of enteral feed called trophic feeding through their GI tract just to keep the cells alive and the barrier intact. Physiology always wins.
All right, we have covered an immense expanse of biochemistry and clinical pathology today. Let's synthesize this deeply. We started by tearing down the simplistic definitions of essential, watching how severe trauma or a single missing PAH enzyme in PKU can suddenly force the body to demand external arginine or tyrosine.
We traced the meticulous nitrogen disposal system, watching alanine shuttle toxic waste away from the muscle so the liver can safely convert it to urea, preventing the cerebral edema of hepatic encephalopathy.
We dismantled the myth of essential carbohydrates, exploring how the liver's gluconeogenesis and ketogenesis pathways prove the body's incredible metabolic flexibility.
But we also saw the devastating consequences of abusing that flexibility with high glycemic index diets, mapping the exact mechanism from insulin surges to receptor downregulation, beta cell amyloid destruction, and type 2 diabetes.
We navigated the micronutrient minefield, treating symptoms as clues to broken pathways. We saw how a lack of thiamine shuts down the ATP-generating enzymes, destroying the mammalary bodies in Wernicke-Korsakoff.
We connected the structural collapse of scurvy directly to the failed hydroxylation of proline in the collagen triple helix. And we differentiated macrocytic anemias by tracking the buildup of methylmalonic acid when B12 fails to metabolize odd-chain fatty acids.
We observed the brutal global paradox of Kwashiorkor's oncotic edema existing alongside the atherosclerotic plaques and lipotoxicity driven by ultra-processed diets.
And finally, we translated all of this to the ICU, learning that preserving the physical architecture of the gut via enteral feeding is the ultimate defense against bacterial translocation and sepsis.
It is a staggering, brilliantly interconnected machine. And listener, this brings me to my final point for you. As a future physician, you're going to write thousands of prescriptions in your career: statins, antihypertensives, insulin. But you must recognize that in the vast majority of non-communicable diseases, those medications are merely chemical band-aids. They're desperately trying to manage the downstream symptoms of the metabolic pathways we discussed today that failed years or decades ago due to chronic nutritional abuse. Diet is the single most powerful, modifiable risk factor you have in your medical arsenal. Do not outsource it. Understand it at the molecular level.
Before we sign off, I want to leave you with one final evolutionary thought to chew on. We spent a lot of time defining what is currently essential for human biology. We define vitamin K2 as non-essential, only because our gut bacteria synthesize it for us.
Right.
But look at the modern clinical environment. If a patient's microbiome is permanently degraded by repeated courses of broad-spectrum antibiotics and a sterile, low-fiber diet, do they lose the endogenous capacity to make K2?
Oh.
If their metabolic pathways are permanently altered by the epigenetic changes driven by chronic psychological stress or environmental toxins, does their internal synthesis machinery begin to fail? Do our rigid textbook definitions of what is essential collapse under the weight of modern living?
That's intense.
Perhaps the future of medicine isn't just prescribing standard dietary guidelines based on 20th century population averages. Perhaps the future is sequencing an individual patient's degraded microbiome and analyzing their specific metabolic genome in real time to discover what is uniquely, conditionally essential just for them at that exact moment in their pathology.
That is a phenomenal paradigm shift. It means the textbook is just a starting point. The real biochemistry is happening uniquely inside every patient you see. Thank you for joining us on this deep dive. I hope this gave you a concrete mechanistic framework to anchor all those flashcard facts onto. Do yourself a massive favor right now. Close the laptop, step away from the desk, go grab a low glycemic index snack to keep that insulin curve flat, take a long walk, and then come back and conquer those boards. You know the why now. The what is easy. We'll catch you on the next one.